let's start.
Good afternoon, and thank you very much for being here today at this conference entitled VR Technology in the Therapy of Anxiety Disorders and Related Conditions. It is my pleasure to introduce you to Dr. Iveta Fajnerová. Dr. Fajnerová completed her training at Charles University in Prague at the medical faculty in psychology and neurobiology for her master's degree, and later obtained her PhD in neuroscience in the same university. She's currently a head of the Virtual Reality Research Center in Mental Health and Neuroscience at the National Institute of Mental Health in the Czech Republic, and her work focuses on the development and use of virtual reality tools in research, education, and clinical care in psychiatric disorders, with emphasis on anxiety disorders, obsessive compulsive disorder, and cognitive impairments. She visited the center by the end of June last year. Today she's doing the conference remotely. We have, it is important to mention that we signed a memorandum of understanding, and we are currently collaborating with her lab in different projects, including one to use virtual reality in palliative care for older adults. So without any further introduction, thank you very much, Dr. Fajnerová, for being here with us today.
It's my pleasure. Thank you for introduction. Let me start. So I will actually try to present some work that we do in the National Institute of Mental Health that is located near Prague in Czech Republic. And I am the head of the research center that is actually using virtual reality either in mental health care or education or some research studies. I will start with a small introduction to VR, just because not everybody might be related to this technology. What I wanted to introduce you to is that there are actually two big approaches that are used in virtual reality glasses. One of them is, of course, a virtual simulation that is created in a computer environment that is completely simulated. However, very often you can also encounter some games or therapeutic approaches that are actually using 360 degrees movies. Both approaches have some advantages and disadvantages, of course. The big advantage of the movie approach is that it's very realistic. You can actually feel like in real environment because it's recorded from it. However, in this environment, you cannot much interact. You can turn around, you can even decide about your position in the video, but you can actually not control what you are doing or where you are going. So it's in some way passive. Well, in virtual simulations, we can actually build any interaction we need for the therapeutic approach, and we can actually adjust it even during the game as we need. So that's why most of the stuff I will show you or we are working on are actually virtual simulations. In general, we can actually find a lot of various approaches how to use VR in mental health care, but I will actually show you three big groups that we are working on. The first is the use of VR in psychiatric care. Here, I will present you mostly VR-based exposure therapy techniques. They are used in anxiety, compulsive disorders, but also in other related conditions. However, we can imagine also use of simulation of some medical procedures and relaxation techniques. Nevertheless, there are also other approaches used in psychiatric care, and if I have time, I will show you also some more of them. The other big group of studies and games we are building is for neurodegenerative disorders. So usually what is done in this field is simulating activities of daily living that are built to actually simulate something that is very natural for the person and which can be used either for cognitive screening or cognitive training. But we will not have time to talk about this today, but it can be next talk, possibly in future. The last group of activities we are doing is building some applications that are used for education, especially of medical students, but also some psychiatric practitioners. In this case, it can be variable games like training applications for difficult communication in medicine, or it can be also symptom simulations that can be experienced from first-person perspective. That can be very useful for students to understand some symptoms or specific conditions of the disorders. So these are these three groups, but I will mostly talk about the first one, about the exposure techniques and the relaxation techniques that are used in anxiety disorders. So let me start on that. First, I would like to explain a bit about exposure therapy techniques because I'm not sure if everybody is familiar with them. But basically, exposure is a technique that introduces some feared stimuli or situation to the usually phobic individual, but it can be used also in different anxiety disorders. And during the exposure, various techniques can be used. The most basic but very efficient one is imagination. So the patient only imagines some situation that he's fearing. Of course, in this case, it can be very effective. However, not everybody is able to imagine the same way. And for some patients, it's very hard to pay attention to such imagery situations. Typically, what is used in psychiatry and cognitive behavioral therapy is in vivo exposure therapy, which means that the patient is exposed to the fear stimulus in real life. However, this is not always possible for reasons that it can be dangerous, it can be hard to approach. For example, you cannot fly with the patient by airplane. However, in this case, VR actually exposure is the best technique how to approach it, because in such case we can actually simulate the same or similar situation in safe a hospital environment while the patient is with the therapist, so they can work on the strategies and methods how to deal with the stress that is related to the situation. So VR can be something like easier way how to approach the stimulus, but usually what we need in the VR exposure therapy is that the in vivo real one exposure is actually following it afterwards, not in the same day, but during the therapeutical process. What is important is that previous studies have already shown that even experiences in VR can actually show some way how to overcome loss of control and fear that is related to these situations, and can be also very effective. When we look at the feared situation, for example, in phobias, what typical the patient fears is that during the situation they will be extremely anxious. And of course, most of the people worry that the anxiety and the stress will just keep rising until something happens. And at this point, they usually already avoided the situation. So they are just leaving it without dealing with the stress related. So that's the problem, what is actually building and learning the body how to fear the situation. So that's why in the context of exposure therapy, we are working with learning methods how to tolerate an anxiety that is related to the situation, and also experiencing that actually the anxiety will not last forever and it will slowly go away. So that's why what the people need to experience during this therapy is exactly how to deal with this exposure, so they can actually or are able in the future deal with this situation in real life. VR exposure techniques have been actually here quite long time, because the first study was done in 95. And it was studied by Dr. Rothbaum, who actually published it in acrophobia patients. And actually, acrophobia is very favorite method, or VR exposure in acrophobia is very useful also today. But I wanted to show you here that even older studies, they are actually that actually showed visual virtual environments that are not very pleasing to the eye. So you can see on the left that these environments are not always looking like we would expect them to look today, because the technology, of course, evolved a lot in the last years. However, studies show that it doesn't matter how it looks like, because for phobic patients, even visual cues that are related or familiar, similar to the situation, can already create a stressful environment or stressful situation. When we looked at some meta-analysis that actually checked if VR exposure techniques can be somehow relevant and can be effective, then we can see, for example, in this older meta-analysis, that VR exposure therapy has been proven repeatedly to be effective in treatment of phobias when it's compared to control condition, which is usually standard care or nothing. However, it's important to say if it's even more effective than standard cognitive behavioral therapy techniques. And this is another meta-analysis that is actually showing that when we compare VR exposure enhanced or somehow improved CBT techniques with standard cognitive behavioral therapy programs, and then even in such case, the studies favor VR enriched CBT. So it seems that really VR exposure techniques can actually improve and somehow augment the treatment methods they are standardly used. However, when we are designing any VR environments, which we actually do a lot in our lab, we have to think about some questions and methods we actually need to use to really keep it targeted on the group that we are working with. Of course, the first question will be how the task should be performed. For example, in some cases, we need the body position to be changed. Some patients are sitting, for example, during relaxation techniques, or can be even lying down during MRI simulation, or are standing because we need them to be exposed and really present in situation, for example, when they are walking or standing somewhere. However, it's also important to think about the content, of course, what the situation should be including. And of course, in this case, a first step is expert decision. So we usually base the environments on some clinical practice and literature review. However, it's very important in every step to target or speak also to the target group. And in the prototyping work, also to ask them to check the environments and give you feedback if it really works, if this is something which would be exposure for them. And of course, it's also important to ask the question, especially in exposure techniques, what the individual steps should be in the exposure scenario and when they should be actually activated. For example, when the intensity of the situation should be increased, and one, it should stay as it is or even be lowered if it's, for example, too stressful for the patient and he cannot manage the stress related to it. Here you can see actually examples from our VR lab in Czech Republic that actually shows that we are actually prepared for everything, for sitting, lying, or standing patients. So you can imagine that the lab has to have more facilities or bigger space for that. So first environment I actually wanted to show you is virtual city environment that we will build for exposure therapies in phobias. This was a bigger study that was done with some partners from Czech Technical University. And in this study, we actually started with acrophobia because it's the favorite, as I told you before. And of course, it's somewhat easy to decide on individual steps of the treatment procedure. In acrophobia, it's fear of heights for those of you that don't know the term. And of course, it's most prevalent specific environmental phobia that it's somehow prevalent in the population. And for the patient, some height-related situations can be extremely stressful, and usually this phobia interferes with everyday life, which means that they cannot either enjoy some recreational activities or just are somehow not allowed to, for example, work or live in higher buildings. So for acrophobia, what we did and what we wanted to do is create an environment and test it using randomized control clinical trial to prove its efficiency. Here you will see a short movie that is recorded from our environment. It's cut from several scenes, so it may not be always connected after each other. However, what it shows is that we are using a high building environment. In this case, the patient enters an elevator that brings him to higher floors. It can start at 10th floors or second floor, depending from the procedure and also from other reactions of the patient. But of course, over the time, using this glass elevator, he should be, or the patient should be able to visit higher floors up to the highest one, and that's 84th floor. Importantly, there are also some other environmental features that allows us, for example, like balconies to look outside, do some tasks, for example, counting the cars below you. So you are actually, so the patient has to look downwards. Or we have like bridges between the buildings or balconies at the highest floor and the top of the building, which is actually also important. For the randomized control trial, we actually randomized the patient between two groups, either active one, experimental group that actually undergoes VR exposure therapy, and the control group who is on waiting list and can actually enter the VR exposure therapy only after the follow-up session, which is even 2 months later. The VR exposure therapy had 3 sessions, so 3 weeks of therapy, which was introduced by some education about the methods prior to that. Here you can see results of this study that actually shows that post-treatment, the experimental group shows lower values of height intolerance scale scores, and also much lower avoidance severity, which means that they are not avoiding in everyday life situations that are related to heights, which is important. Which you can see here is that in follow-up, we can see that the group that undergo or performed in VR exposure therapy actually shows that the effects are prolonged, which is extremely important because this shows that they actually were able to use the learned methods, for example, relaxation techniques and so on, and use them in the real life situations so they are not avoiding them during the real life conditions. Of course, acrophobia is not the only typical phobia that is treated using VR. Another one is aviophobia, which is very favorite also for the reason that it's quite demanding for patient to travel around. Fear of flying is actually also very prevalent, and it's very complicated for the person living with it because they are not able to travel bigger distances. And of course, it's very problematic to treat it without VR exposure because there are not many other options how to expose themselves to these situations without actually flying, which is of course costly and also very problematic to do. So what we did, we built an exposure scenario for aviophobia. You will see another video which is actually not showing first-person perspective, but only go through the environment so you can see that everything is included and that the whole procedure can actually include the whole process that is included during your travel when you are traveling to some space around. And of course, importantly, there is also section where the patient sits in the airplane and it's actually, and the airplane is leaving the airport. And this can be, of course, very stressful for the patient when they have to experience it. This can be actually improved with various feedbacks, some platforms and different methods that can actually provide motor feedback about movement of the airplane. Here you can see actually the data from our experiment that just finished, and it's prepared for publication. So this is data from our group of patients, that it's over 40 people. And you can see here that we actually did a scenario with various steps. You can see here 14 selected steps from starting on the subway station and traveling to the airport, up to entering and boarding the plane, and of course departure announcement and takeoff. And you can see how the anxiety increases over the individual steps, and where it's actually different from the control group responses, who is actually not stressed by this scenario. Of course, other specific phobia that will be typically approached using VR situation is claustrophobia. For this specific condition, we can see a lot of studies that show usage of elevators, some closed buildings with small rooms, or corridors, and of course MRI procedures. So in our case, we actually used immersive environment again in the virtual city, which combines with the other phobias if necessary. However, in this scenario, we used 3 different environments. It's the elevators, which have 3 different sizes. These ones are not open but enclosed. Then underground parking lot with 3 floors, and subway station with corridors, platforms, and of course crowded trains. We have also neutral environment just to show during the validation process if the patient reacts differently to this control environment. In each environment, we are using again several steps, the same number of steps, in this case 4 selected ones, like entering the environment, taking the subway or elevator, and then of course getting stuck and waiting there during some specific time period, for example 5 minutes, until the elevator or subway is repaired. And here you will see again some movie from the environment that we recorded, so you can imagine how the situation looks like, even though this is an older version, and you will see situations where the patient is getting stuck in. So it's the last I showed you in the scenario. And we will see also what happens when the elevator is blocked and is stuck in some floor, which can be, of course, somehow included with various visual or also sound effects that will actually provide very specific feeling of the situation. But of course, importantly, we always let the patients out of this situation. Here it's again illustration of responses of our patients and control subjects, which are presented in blue here. And you can see again that phobic patients rate their anxiety related to individual steps of this scenario much higher than in case of control subjects. This study has been already published, even though it's a smaller sample. It was a validation study. However, over the time, we actually built a virtual city environment for various other phobias, which I will not present here. In all of them, we are always doing validation and effectivity studies. So I hope you will read them in some papers over the next few years. So just to show you that we have also environments, for example, for agoraphobia or contamination related fears and so on. However, in relation to a claustrophobia that I spoke about before, we have also another application that is actually used for a feared medical procedure of magnetic resonance imaging, which is very often avoided by patients with claustrophobia, agoraphobia, or other anxiety disorders. For this reason, because we have our MRL lab in the National Institute of Mental Health, we built actually a perfect copy of it, including all the rooms without the mess in the rooms, of course. And what you can see here is an illustration from the environment and personnel opening the door for the patient who is entering the room. And it's actually after a while when he fills out one point questionnaire asking him about the anxiety and fear of this exposure. And then he's lying down. Of course, in this case, it's extremely important to align the physical body patient, virtual body presented in the VR, which actually can be adjusted for man, woman, child, and so on. I will not show you the real VR exposure in MRI because it's extremely noisy, but it's quite realistic. And what is important for us that it's helping the patients to prepare for the MRI procedure. I will not show you or I'll go through individual methods used in the validation study, but I wanted to show you again the repeated evaluation of anxiety during this procedure, which you can see here again between phobic patients and controls. Even though here you can see a bigger variability because we have also patients here who are suffering from other anxiety disorders, so it's not always phobias. What is important is that the most stressful situation is, of course, putting on the head coil and entering the tunnel. After this, if patient can handle the situation, he can already stay in the MRI for quite a while. For our experience is that we usually need also repeated exposure to prepare the patient for this situation, but we need at least one VR exposure and one real one, which is combined, of course, with this in vivo MRI procedure. I wanted to show you actually also the comparison with the previous three environments that I showed before, elevator, subway, and garage. You can see the MRI is similar to the stress related to elevator environment. However, this group is a bit different. While in the first study, it was only claustrophobic patients. Here is a mixture of other phobias and anxiety disorders. That's why there is also bigger variability. Pardon for that. And I wanted actually to show you that exposure techniques are not used only for anxiety disorders. This is an example of work of my colleague, Anna Francová, who actually created with other colleague borderline some environment for borderline personality disorder. And this environment is used for exposure, not yet for therapy, but it's validated in the meantime to show if borderline personality disorder patients would actually react differently than healthy controls or social phobia patients to social situations, for example, like that, where you are sitting down in a train, the train is full, but even despite that, the other subject who is walking in is not sitting beside you. And that can be interpreted in different way. And usually borderline personality disorders tend to interpret it as they are either smelly or somehow avoided by the other person. Of course, other big category for phobias, it's animals. But I will not show you studies about that because we have smaller samples in them. And also because this category is also related to a bit different condition, and that's OCD. So we actually use a house environment where these animals are used also for phobias. But basically this environment was built for obsessive compulsive disorder. The reason for it is that also here we can actually use exposure techniques, even though they are aiming on different symptoms. In OCD patients, just in case you are not familiar with this disorder, typically we can see obsessions and compulsions. Obsessions are intrusive and recurrent thoughts there actually, or images and urges there. The patient is thinking about various times of the day, and to resist them in some way and to reduce anxiety that is related to these obsessions, the patients usually create some compulsive behavioral acts which are repetitive, something like rituals, for example, how many times they are washing their hands or checking if they close the doors, or they are arranging stuff in some particular way. But they can have also mental compulsions, for example, counting or similar approaches. Importantly, sorry for that, just get back to it, there is actually various symptoms in obsessive compulsive disorder. That's why over the years, some dimensional approach has been used to divide them to some subtypes, typically divided to contamination and cleaning, symmetry and need for ordering, fear of harm and checking behavior, and then hoarding, which has been recognized recently as a separate compulsive disorder. However, over the years, several studies actually show that VR or 360 movies can be actually used to expose patients and either diagnose them using these environments or use these environments for treatment. Usually these environments are aimed for checking behavior or contamination. Many of them don't actually aim on all subtypes at the same time. Over the years, we actually built OCD house, we call it like that, that actually was created to cover all subtypes and all other dimensions that they can think of in OCD. So we have all related stimuli present in the environment that they can be used as needed. We already published a validation study that used these environments and selected features. Here is a list of 10 specific scenarios or stimuli that were presented to the patients during the validation study. And we are actually showing in our study that the anxiety related to this OCD symptoms can be provoked also using VR exposure. So here you can see a cumulative score or total score of anxiety or distress that has been evaluated by the patient in individual situations. So they actually rated each of these situations separately, but what you can see is the total or cumulative score. That's why it's up to 50. What you can see here is that in our 44 patients compared to healthy controls, there is a huge difference. Never, there's also huge variability. The reason for that is that unlike phobic patients, the variability in OCD is related to different dimensions or subtypes I was speaking about before. But in this case, we actually show them 10 various symptoms. They are related to different subtypes. That's why some of the patients could react to all of them in some cases, because they are reacting both to contamination and checking or symmetry symptoms or stimuli. Sorry for that. However, there are also patients who have only mental compulsions and mental obsessions, and in such case, it's possible that they don't react to anything that we are showing them. And this huge variability is, of course, a big problem in VR exposure, but it can be actually applied or used using this dimensional approach if you have a huge variability of stimuli that you can use in these patients. Here is again some short movies that you can see from the environment, even that it's the older version of it. Here you can see on the left upper corner, it's the contamination stimuli, and this is more intense situation, including some blood and other bodily fluids. Then on the right side, you can see another situation in a patient who is actually reacting to fire hazard. So he's afraid, and his thoughts are mostly related to the possibility that he will forget to turn off the gas stove or open a fire in the environment, and his house will burn down. Particularly this patient actually gave us feedback that, oh, it's virtual. I actually don't see it. I don't think that they will react to it. It's doing nothing to me. And you will see over the time that he will actually check various stimuli and check, for example, if something burns, if it's on the stove and so on. And after this, you will see his reaction after he goes out to take out some stuff. And after that, he cannot actually return because the door is locked. And this is his reaction after 2 minutes waiting, when he checks through the window if the fire didn't start in the environment. So you can see that even if the subjective information provided by the patient is sometimes showing you that it's not working, his behavior can actually tell otherwise. Another, of course, is the subtype of symmetry. On the left bottom corner, you can actually see a patient that over the therapy actually is not creating symmetry, but asymmetry. So he is asked actually to change the direction of various pictures or stuff in the environment, and he has to sit down and look at it, because of course that's quite stressful to not be able to put it back. And the last video shows hoarding behavior. In this case, we are working with a patient who is actually asked to take out the boxes without looking in them. So that's quite complicated, of course, for hoarding patients to get rid of stuff they are actually living with. Of course, over the years, we built quite an interface for therapy, so they can actually select which symptoms they want to work with the patient. They can combine them as they want or as they need, because in some patients we see combined subtypes. In some, it's very specific stimuli they are reacting to. But we, as I told you before, we are using this environment also for different disorders. For example, in phobias using animal stimuli. But we have also different conditions. For example, general anxiety disorder, which we can use this environment for. We have there a so-called dark room, which is an environment that is used for intrusive thoughts, which the patient writes down, and then he has to sit down for a few minutes and look at them without being able to interfere with them in any way. And this is a specific technique that is actually used in cognitive behavioral therapy, both in general anxiety disorders, OCD patients, and also other conditions. Of course, also in this environment, we need gradual exposure. So we need to increase the intensity of the stimuli as we need. So it can be completely clean up to complete mass. So it really depends what we need. And over the years, we actually also tried to increase the intensity with some specific smells. And the reason for that is that some of the patients report that, for example, they don't react to gas or to some contamination stimuli if the smell that is related to that is not present. So that's why over the time we actually tried various options how to provide the smells during the therapy. Currently, we are using standard aroma diffuser, but we are testing also VR olfactory device that has been shared by our colleagues from Sweden. Here you actually can see one example of a patient who was working with or without olfactory stimuli during the VR exposure. And I just wanted to show you that actually, in most cases, the smells provided during the exposure increase the intensity of the situation. So usually the anxiety is higher. However, in some specific conditions, it can go also the other way around, and we have to be aware of that. For example, smoke related to fireplace can be actually also pleasant, and it can actually bring back some pleasant memories. So in these conditions, it's better, for example, use the specific odor prior the person sees actually the specific stimuli. For example, by the doors, he can already feel the smoke. So the reaction will be higher because there is this alarm in his head telling him, oh, okay, maybe there is something on fire here, so I have to check it. So it's a bit different than when he sits and sees that the fire is actually there and nothing is happening. Over the time, we actually ask also some other therapists, apart from National Institute of Mental Health, to use this app in different classes, that it's more easy to use. And they tested actually the application on 36 patients, that we have very nice feedbacks from them, showing that it can be actually used also in a standard daycare. So it's not so demanding in means of time or specific care with the patient. Okay, so now we will move a bit to, let's say, more pleasant talk, because it will be not about exposure to something that is not very pleasant, but it will be more about relaxation techniques. So, of course, also these techniques are very often used both in anxiety disorders, but also in various other conditions, either to release stress or decrease anxiety related to some procedures. Over the years, there appeared a lot of various apps that you can find either online or on YouTube VR, or using various YouTube VR channels that are actually showing various relaxation techniques, meditation techniques, or swimming with dolphins, and so on. So there are many approaches to that. A few years ago, also we built a VR breathing application that was actually created using belt sensor to provide feedback to the patient if they are breathing correctly. Because usually our techniques used in anxiety disorders are not related only to relaxation or meditation, but to focused attention, and usually to some rhythmic, deep breathing techniques. They are trained during the cognitive behavioral therapy, and the patient can use them anytime they need in the future. Here on the picture, you can actually see in the middle two breathing patterns of the same patient who used the VR application for the first and the second time, which is below. And you can see that already one training session, which is actually for a few minutes, can be enough to train the rhythmic pattern that should be used during the relaxation technique. And we also showed that subjective anxiety that was rated before and after using this app shows actually decrease of the anxiety in these patients. Currently, we are building new version with various environments, which we hope will be used also in Montreal in few months. However, the reason why I was speaking about the relaxation is also other medical care, that is because these techniques are actually used also in patients outside of psychiatric care. Typically, we can think of pain management techniques where the various relaxation or distracting games are used to distract the attention of the patient from some, for example, procedural pain. But other big group where VR can be actually used as palliative care, that Alexander was speaking in the beginning of the presentation. And of course, here it can be related to pain relief, reducing of anxiety or tension, but it can be also used to activate the patient in some way, for example, in case of elderly or seniors. When we look at the techniques that are used, usually they aim for decrease of physical and psychological discomfort. In means of physical is usually related to pain relief and release of fatigue, while in psychological symptoms, they usually aim for anxiety, depression, and of course, stress reduction. However, the techniques that can be used for that are actually quite variable. Typical what we can see in palliative care, it's various experiential therapy techniques, which actually means that they are using games They are showing soothing environments, for example, some walks in nature or ocean swimming and so on, or they show new experiences to the person. For example, they can actually provide them to tick something, some of the goals on the bucket list, for example, swimming with dolphins or visit some new place where I didn't or wasn't able to go during my life and so on. So this is one approach. However, what I showed you before is relaxation therapy that is usually associated with mindfulness techniques, meditation, and deep rhythmic breathing techniques. However, especially in elderly, we can also see reminiscence therapy that is used to recall some episodic memories from their past that actually helps to provide them some continuity in their life events. And these techniques can be also very comforting. So they usually go back to some very pleasant memories from their childhood or young age. And they can also be somehow induced by some familiar places shown in VR glasses, for example, going towards going to some city which where I was when I was young, and I visited it with my husband and so on. So you can imagine that these reminiscence techniques can be actually very positive for the patient, and very often they show higher activation, so they are actually able to speak more. They are more socializing than without using these techniques. However, I was looking for some systematic reviews and meta-analysis on this topic, and a meta-analysis from 2 years ago actually shows that some of the studies that have been already done in palliative care are usually done in small samples or don't have a very good methodological approach. So, for example, they are missing some control groups and so on. So even though there is a lot of studies already done in palliative care, this is only selection of them. They are usually assessing various outcome measures. So it's very hard to compare them in between. But mostly they are aiming for anxiety or pain relief, and typically they are testing feasibility or accessibility of the method. However, the systematic review shows that it's actually hard to prove the effectivity of these methods in palliative care, which is related to the methodological issues that I was speaking about before. And even though some of the studies show some improvements in, for example, pain relief or depression and anxiety decrease, not all of them are showing this effect. So even though most of them show that VR can be beneficial, it's very hard to tell from this meta-analysis that it can be proved at this point. So what do we need in the future is actually to increase the quality of the research that is done in palliative care, which means larger studies groups, having comparator arms or control group in each of the studies. And of course, we have to check also for the content and quality of the applications that are used, because there is quite a huge variability in that. And the poor quality of the applications can actually lead even to negative experiences for the patients, for example, headaches or nausea. Of course, it's important to check for methodological issues, so be very rigorous and use of standardized outcome measures. And of course, in means of clinical care, there is another issue related to comparison between acute and chronic pain, which is, of course, very typical for palliative care. And also, it's good to check for effects of disease progression that can, of course, alter the results of the study as well. So all these factors should be actually checked for in the future studies, and I hope that also our comparative work or collaborative work between Montreal and Prague could help with that in the future. In this moment, we are actually doing small studies also in palliative care in children in Czech Republic, which are done in collaboration with Hospital Motol. We already did a feasibility study, which worked quite well, but without control group again. So in this case, we can show that, for example, anxiety and fear in children is decreased after VR exposure in this case to some games that have been selected, usually educating games. However, we need randomized control trial that is actually currently running, and in the future we want to compare it with VR relaxation techniques as well. So I just want to check my time. I think I should be already finalizing. I prepared some slides only to show you that it can be used, or VR can be used also in other psychiatric disorders. Just this is a picture, a bit provoking, from my colleagues, Dr. Kaklapilova from sex-related laboratory that works in our institution. And they're actually working now with Patrice Renaud from Filipino Institute. So we have again collaboration with Montreal. But there are also other techniques, for example, body swap illusions used, for example, for domestic violence offenders to show them how they would feel in the situation where they are actually presented in the environment in the body of the female victim. So this will be showing actually how the app can work, and it can present various intensity of aggressive behavior from the other avatar present in the environment. But of course, exposure techniques can be used also for provocation and of symptoms in addiction disorders. For example, here is virtual bar created by our colleagues in Pilsen, or some other options or games built in other labs.
Safe to let defenses down and see what actually happens.
Another example, this is illustration from schizophrenia. One of them is again in Montreal, where the app is used to create avatars that represent actually hallucinations of the patients. The other app built in Oxford is built for paranoid patients to provoke the paranoid symptomatology, and also to work in the therapeutic session with the thoughts related to these situations. And finally, VR can be used also for group therapy, which is a quite new approach that has been starting over the COVID pandemic, and it's spreading around. So many sessions, especially for social phobias, are nowadays done also online using metaverse. So this is it from me. So I will probably go through education techniques without presenting them because we don't have much time. I just wanted you to show that we can also use VR in education of patients, of medical students, when we want to teach them, for example, how to treat anxiety disorders or how to recognize some specific symptoms. So I would say this is all from me. So I would like to thank for your attention. And of course, I will be happy to respond to some questions either now or anytime. So you can also write me to my email if you want to ask something after the session online. And I want to do one more thing, and that's to invite you for the international conference on disability, virtual reality, and associated technologies that will be actually organized by me and my colleagues in Prague this year. So you are welcome to send the abstract and visit us in Prague, also in person during September. So thank you very much for your attention.
Thank you so very much, Dr. Fajnerová. Now, well, we have a very short time of questions. Yes, Dr. Rainbiel.
Yes, thank you very much for your presentation. This is really, you're covering a very broad scope of potential applications. I have two small questions. One is whether you're also measuring physiological responses, including brain responses, to validate the verbal reports of the patients. The other question is partly methodological and partly theoretical. In some studies where we're using or trying to implement VR for pain control, we're trying to compare it with other types of interventions based on mental imagery, relaxation, hypnosis, and so on. And one thing that we find is that it seems that there might be some overlap in the cognitive processes or mental processes involved in the, for example, hypnosis and VR. But then there seems to be some maybe opposing effect or incompatibility between these different methods. So the conceptual issue is, can we dissect out the mental processes involved in VR interventions and try to combine them with different types of psychological approaches? And are there conditions where it's maybe counterproductive to bring in VR when you're using other types of interventions? And of course, the methodological challenge is, what is the appropriate control intervention? Or, I mean, of course, there's no placebo control for this type of intervention, but what should be the appropriate control?
Okay, thank you very much for the questions. So for the first one, we are actually using some physiological measures depending from the procedure. For example, in phobias, we usually do physiological measurements, ECG or skin conductance and so on. They usually relate to the subjective responses, but it's not always like that. And we actually tend to rely more on subjective than the physiological measures for the reason that it can be actually very important for the patient to feel it like that, even though his physiological response is not so huge. Of course, physiologically, we can usually see the anxiety increasing and what is happening there. The only trouble usually in the measurements is the baseline, which is actually sometimes hard to get. The reason for that is anticipatory stress that is related to phobias when they're already coming in for the therapy. So it's hard to calm them down in the beginning to get the baseline correctly. But of course, you can still see the increases during the rising intensity of the conditions during the exposure. However, in some conditions, we found out that it's quite problematic to measure correctly the physiological responses. One of them is OCD and obsessive compulsive disorder. We either have some patients who are actually reluctant and they don't want to use physiology because it's usually touching the skin, which is problematic in some of the patients. And the other problem that we have in OCD is that the anxiety doesn't always come directly with the stimuli presented. So unlike in phobias where you are presented to the situation that already stresses you out, so you can see the anxiety is coming, in OCD patients, it's quite variable. So you can have, for example, situations where the contamination stimuli is presented and the patient is, of course, feeling some anxiety. The obsessions are coming related to it, but it can take some time, so it's not right away. And also it depends from the behavior that the patient presents in the environment. Sometimes they can also mentally do something we don't see. So for example, calming with some rituals we cannot see or relate to, even though we are of course asked not to do that. However, other problem is that when you are presenting them to some situation that normally would provoke compulsive behavior, that are actually avoiding during the exposure, because it's exposure with response prevention technique, which means that over the therapy, you are actually asking them to stop and not do the compulsive act, and or shorten it as necessary. So it can actually happen that the stimuli that is there to provoke it doesn't provoke the anxiety yet, or it's not so strong to see the physiological response, but preventing the compulsive behavior will be. But sometimes what we see in these patients is that the highest anxiety actually comes after they are leaving VR because they couldn't finish it. So they couldn't finish the compulsive act. They are leaving, they didn't clean their hands properly, they didn't do something properly as they are used to, and because they are out of the environment, they cannot do it anymore. So sometimes what we see that they are actually reporting the highest stress level when they are coming back to the group and speaking with the others what they actually got through, what happened to them, how was the experience, and then the biggest anxiety comes in. So it's actually hard to measure in some of the groups. So that's why I'm just saying that physiological measures are not always the perfect way how to do it in some patients. And also in laboratory conditions, of course, to prove something, it's perfect. But for therapists, what we usually see, for example, when we tried the study in OCD with daycare centers somewhere, the psychotherapists are not actually willing to use some extra measures, extra sensors, and some stuff that has to be done over the therapy because it takes time. You need to align it and to measure properly, and of course during practical use of therapy it's not very useful. So I hope I responded to the first one. And for the
Sure,
second
yeah,
one,
well.
yeah, it's actually I'm not sure if I got it, but for me to divide some mental processes, it can be quite hard. When I do some physiological measures, for example, using MRI, we can have some control condition that should actually take away everything that is related to vision, to thinking about stuff, and so on. But anyway, to take away something that is related to the experience, it's quite hard, especially that's why, because in many exposures that we are doing, it's related also to the feeling of presence in the environment, to what they are doing. They are moving a lot of around. That's another problematic issue in physiological measures, that you have a lot of artifacts, so it's not so reliable all the time. So it's not always relaxation and sitting down, where it's easier. And yeah, to be honest, when we are trying to prove effectivity of some method, we usually do either comparison to standard care, which is of course the basic and most simple way how to do it, or we are using similar or not related VR technique. So for example, now we are running a clinical trial in OCD patients where we are comparing VR exposure techniques that is combined with cognitive behavioral therapy and standard programs. Well, the other group is actually doing the same program, but instead of VR exposure, they are using VR for cognitive training of mental flexibility. So it's completely different approach, but they are still using VR games at some point, and the frequency is the same and so on. So this is the way how we try to avoid the effects of, okay, if they are using VR, it's new, it's fun, and for some reason it will be just effect of that we are spending more time with them or something like that. So we are trying to do it this way, but it's quite complicated.
But have you tried mental imagery, like exposure therapy through mental imagery versus virtual reality? Because to me, this is one of the challenges we have using hypnosis, because hypnosis for pain management uses mental imagery a lot. So that seemed to be a reasonable control to demonstrate whether
actually,
virtual reality brings something more than the potential therapy that would use similar approach.
Actually, we didn't use this technique, usually also for the reason that in the standard cognitive behavioral therapy, we already use this technique as part of the standard program. So every patient has it. So it's hard to take away from the program. But we are planning now a study in social phobias where we were thinking about using this technique as a control condition. Nevertheless, we have also some patients who have actually trouble to do the imagery work. So it will be quite a problem of the selectivity of the methods. So let's say that for some patients, it will be more appropriate to use VR, and for some of them imagery, but we cannot decide. It has to be randomized. So then you will have also a lot of people who are not finishing the study, for example. So that's a complication. But actually we have also some conditions where we don't use VR. For example, what we avoid in therapies in anxiety disorders is traumatic experiences. So if the patient has traumatic experiences, we don't include them in the studies, even though they have OCD, they have specific phobia. The reason is that VR exposure is quite, let's say, immersive, and very often the situations they represent are more complex, or the environments. So it can happen that we will trigger something we didn't expect because the patient is not speaking about that in the therapy, so we don't know what it is. So that's one of the conditions which I don't use VR for. But of course, VR is perfect for PTSD, but it has to be aimed for that. So it doesn't, it cannot just happen that it will be by accident. So we need to focus on that specific goal, and visually, or usually that's not the reason why the patient came in originally. So that can follow up after some other therapies that are coming.
Thank you.
before.
Thank you very much.
Thank you very much. Well, we spent 10 more minutes of what was expected, but you have the email of Dr. Fajnerová in case you want to contact her for further follow-up on this. And of course, an invitation for this interesting conference on disability, virtual reality, and associative technologies. Thank you so very much, Dr. Fajnerová.
Thank you very much for inviting me.